I just presented a trial of Waldenström's macroglobulinemia, rare disease, using Acalabrutinib, which is one of the newer BTK inhibitors. This was a single agent study, just using Acalabrutinib either in patients who'd never been treated, so this is an elderly, frail population who couldn't receive conventional treatment. There were 15 of those patients, and then a relapsed refractory group of patients who'd had at least two, many had more lines of therapy than that. So single agent, highly active, response rate over 90%, 2-year overall survival 90%, with very impressive progression-free survival at 2 years, 70-80%. So highly active, highly durable responses. The disease doesn't completely go away. You can still detect it, but you see a very rapid rise in hemoglobin. At the same time, you get a very rapid fall in the paraproteins. The patients feel great. Quality of life goes way up. So highly active and not much in the way of side effects. A little bit of headache, which is one of the side effects you see with this drug. It's temporary. And if you get the patient to drink caffeine, it goes away. So coffee is very good for it. It's a strange side effect, but it does go away. And then the usual kind of things we see with the BTK inhibitors, a bit of diarrhea, some bruising and bleeding, but not the cardiac problems, the atrial fibrillation that's been seen with Ibrutinib. So slightly different side effect profile, but again, another highly active drug, just as Ibrutinib is. Difficult to know how we're going to discriminate these various agents. The other thing in the session I've just been at was looking at Ibrutinib plus Rituximab, which seems to be better than Ibrutinib in the context of Waldenström's. Might be that if you add Rituximab to Acalabrutinib, that gets better still. So it's, that's the game, but the outcomes are extraordinary in these groups of patients.